so simple to me as a practicing physician on this side of the fence. It doesn't seem like addressing any of these issues would make such an impact, but I have been proven wrong, which is honestly quite sad, because it seems as though there's a lot of people who are maybe taken advantage of, disenfranchised, neglected, abused in the system. And you always know that's going on some level, of course, but to hear how broadly experienced it is, especially in the pain management world, is it's disheartening, to say the least. So I'm hoping that we're able to provide some hope and insight and light to these issues. It all started with the term interventionalist. Actually, I was in clinic, and I was enlightened to this idea that the word interventionalist may be not the best word to advertise yourself as. And, I've said it before, but it's true. This is something that in our community, the physician community, we use commonly. It's almost like a badge on your jacket. Well, I'm a pain interventionalist. Oh, cool. We see it on billboards. It's advertised. I think from my perspective, the way I looked at it is, well, this is a person that wants to dedicate their career to performing procedures, but didn't really think much beyond that. The more I work with pain patients, I see, oh no, this is kind of a way that you can tell if they're actually not going to be working for you, right? They have a very certain way of practicing. And, if all they do is injections, well, pain is much more than an epidural injection, right? Pain is much more than a joint injection or a stimulator, right? And so really you're not a pain doctor. You perform procedures. Okay, we need those procedures. But as a pain patient who expects to be treated as a whole person, I can see how that would be very disabusing to the whole idea, right? So yes, so we have many disenfranchised pain patients, and oftentimes they're corralled into these predetermined treatment protocols that are dictated by broadly applied protocols. And the concept of individualized care is sort of thrown out the window, right? Well, you don't get prescriptions unless you do this. Well, if you scored this on this one particular screening questionnaire, then that disqualifies you from one particular treatment. Or, which even makes more sense, I say that sarcastically, we're going to reduce your pill count from 90 to 70, let's say, in a month, just based on how you scored. Doesn't really make a whole lot of sense to me. So I'm glad that we're talking about these issues, because, again, who else is talking about it? But this seems to, again, be a commonly experienced theme. And not to totally throw out the baby with the bathwater, there are reasons why these things exist. There are reasons why somebody may say, hey, Mr. Smith, I noticed that you're pretty high risk on these questionnaires. Maybe we need to adjust your treatment some so that we can maximize your safety, right, without actually causing harm, right? So there are reasons for that. I think the big issue, and this is what I'm hearing, is that when it's so broadly applied that there isn't even a conversation with the patient. It's like, well, this is just how it is, so take it or leave it. Wow, I would say as a patient I would be pretty upset by that. Much similar to how, if you decided that, for whatever reason you did not want 100 vaccines given in one particular visit, right? You should be able to have that conversation with your doctor. You shouldn't just be discharged as some conspiracy theorist that is all of a sudden putting everybody at risk. There is such a thing as patient autonomy, and I think a lot of doctors have forgotten that, unfortunately. Certainly the healthcare system at large. So
again, how does this apply in pain management? Well, we talked about ACE scores, right? We talked about dealing with a history of alcoholism, even if it's remote, even if it's stable or no longer active, right? How that impacts your care. We talked about the abuses of forced tapers, specifically opioid tapers. Even in the face of multiple studies that show the dangers of forced opioid tapers, this is still happening. Patients are still suffering. And again, it's applied with a broad brush. And as we know, anything applied with a broad brush really causes a lot of harm in a lot of cases.
Show the dangers of forced opioid tapers.
I was thinking in the last week or so, what else could be contributing to so much anxiety, as it relates to seeing your pain doctor? What's the uncertainty? What's the hesitancy, right? We know pain patients will wait 5 to 6 years on average before seeing a pain doctor, right? They will live with pain for 5 to 6 years before seeing a pain doctor. And there's lots of reasons for that. There's the fear of falling victim to, let's say, pill pushers, right? There's the fear of being pushed through a bunch of procedures that maybe cause more pain than take away pain, right? The cost of it all, being treated as less than human, right? When you're in your most vulnerable state, dealing with pain. There's lots of reasons, and certainly history has created a stigma around pain physicians as a whole. Pain management as a whole is almost a dirty word, and that's all understandable. A lot of those reasons were given to me when I was first interested in pain management, and my colleagues were saying, no, don't do it. It's a hard world, both professionally and even dealing with patients. It can be a challenging place to practice. But I think, a huge part of this, and this is what I'm learning too in engaging with y'all. I mean, you all are coming from different parts of the country, right? I'm in Texas, so we practice a certain way in Texas. We even practice differently across city lines, county lines, right? But we're talking nationally. The rules are different. The state rules are different with regard to how these medications, these controlled medications are handled, how insurances approach certain procedures, what's covered, what's not. It's so variable. But taking all of those extra factors out, even the physician itself, I can't think of it. Now, again, I'm not in another specialty, so if you're another physician in another specialty, please feel free to comment and correct me. But I will tell you this, from my perspective, it does seem like pain management is unique in the sense that you can have all of these graduates go out into the world and practice so differently from each other, right? There does not seem to be a common core connection with how we manage pain, except, I will say this, the common core exception is to reduce the use of opioids. Like it or not, that's the reality. That's what we've been trained to do. That's what the system wants you to do. So that might be the one unifying factor, but everything else, in my experience, seems different, right? You have doctors that absolutely will not touch opioids no matter what, and they think it's some sort of like virtue, and they virtue signal other physicians. Well, I only have 5 patients on opioids. Okay, well, good for you, whereas others, are more medication friendly, and maybe some are too medication friendly, right? And unfortunately, those people may be causing harm too. We have patients that will perform epidural injections and joint injections, but not do stimulators, right? I know doctors that went through board certified fellowship and were trained on how to do stimulators, but then got out into the real world, maybe didn't feel comfortable with it, and no longer do it. Same thing is true with peripheral nerve stimulators. Same thing is true with ion facet joint fusions or Minutemen interventions or kyphoplasties, right? There is a plethora of minimally invasive procedures that can be offered with good effect, right, for a pain patient. But the heterogeneity of training and then the physician level of comfort and their patient population and what they think they can apply to their patient population successfully or not, it's so different. I have a patient or a physician friend that does pain pumps, okay? A lot of doctors still do pain pumps. A lot of doctors don't. I happen to be one of them. So I say all this because as a patient, you kind of don't know what you're rolling into. And it can be very rattling to have certain expectations that go unmet, right? And so that is, I think, a huge problem in what contributes to, you might say, varied patient experiences with their pain doctor. Of course, a lot of this has to do with customer service. There's no doubt about that. How a doctor speaks to their patient, how they make them feel heard, right? How well the doctor and the patient are able to move forward in a collaborative way, right? I think there wouldn't be probably nearly as much issue with most things as long as it was communicated effectively. It's like, hey, I see where you're at. I hear where you're at. Now I want you to understand where I'm at. These are the concerns I'm having, right? Like, how come we can't have more of that discussion? Because it seems like to me so many comments and messages I'm getting from this community is saying almost the exact opposite, that their doctors are dismissing them, or the patient will lay it all out and say, please, what can you do to help me? And the doctor will say, well, there's nothing I can do for you. Have a nice day. Well, it's like, wait, what? You call yourself a pain specialist or what? Because I'm a patient. Nothing is super crazy about my condition, but you're just telling me there's nothing you can do to help me. So I think as part of your role as a physician, you need to do a little bit better than that. That's what doctor means. It means teacher, right? At the end of the day. That's why I'm here. I love doing this. And I love engaging patients. I have whiteboards in my room behind me when I'm doing my exams and talking to patients. I'll draw stuff on there. Is your doctor drawing stuff on there? What is happening to bridge the gap of communication? Because that, I think, would just solve so many problems. That's definitely a big issue. And what we learned from Sarah last week and her horrendous experience with her spinal cord stimulator. Customer service matters, right? Clearly, that should have been a physician-solved problem. That should have been a problem solved by the physician, flat out. I hear some patients tell me that, their doctor schedules procedures on a Friday and then has their office closed on a Monday. That's not actually super uncommon. I see that at several locations I've worked at. Maybe not closing on Monday, but you get the idea. What is the point of doing a procedure on a Friday? As a physician, why would I want to spend the weekend now living in a moderate level of anxiety, wondering if my patients are all okay? Maybe a lot of doctors don't care. I don't know. But I can tell you one thing, if I were a patient, that's not what I would want. I would want my procedure scheduled in the early part of the week. Maybe Wednesday at the latest. Maybe Thursday if it's an emergency. But to go in on a Friday, unless you're in the hospital, to be discharged home with your only option of connection to your surgeon being the emergency room over the weekend, that just seems a bit ridiculous. And then to have a device put in you that is malfunctioning and you can't get a hold of your doctor, just so you know, there are state phone numbers you can call to report that kind of shenanigan, right? We're actually required to post that phone number in our waiting room. It's part of your admission paperwork to our clinic. If for whatever reason you feel like your care is substandard, then you can get the state up on my clinic, okay? And quite frankly, it sounds like there's a lot of situations where that might be necessary, especially if you have a device put in you that's not doing what it's supposed to do and you can't get anybody to help you. I can tell you, my friends at Boston Scientific, once they got word of this, they jumped on it quick. That's all I can say about that. But they are definitely, in my experience, the people that I work with are not ones to abandon their patients. And Boston Scientific is a huge company. I mean, I'm sure you guys realize this, but it's one of the largest medical device company in the nation. They're doing a lot of great things. So, with any large company, you're going to have bad apples, bad, employees that work for it, that type of thing. But again, in my opinion, as the person who owns the patient, as the person who's responsible for the patient, who's carrying the malpractice insurance, who has to answer to the state and the federal government, the patient's my responsibility. So definitely, if your doctor is going to hold you accountable to some plan of care, there's nothing wrong with you holding your doctor accountable to the plan of care. It's just that simple. It doesn't have to be adversarial, like I said. Just set your expectations. Know what you're getting into. I'm not saying it's your fault as a patient if you were chewed up and spit out by the system. Not at all. This is let's say a proactive recommendation. If you are going to go to a pain doctor, or any doctor for that matter, and especially in today's healthcare system, know what you're getting yourself into. Research your doctor. What type of procedures does your doctor do? What kind of reviews is your doctor getting, right? There's nothing wrong with interviewing your doctor. I know we talked about the idea of doctor shopping in the past. Keith has brought that up as a positive thing that you should do, and I agree. I think from my perspective, I wouldn't call it doctor shopping because that term is a red flag in our community. So I would refer to it as doctor interviewing. You're interviewing your doctor. That's nothing wrong with that. That's a responsible thing to do. And by the way, your doctor is totally used to that, or they should be. I think a lot of times, they come in with the white coat and they think, well, everything I say is next to God, so take it or leave it. Okay, but they didn't get to that position acting that way, just so you know. No, they've been interviewed 30 times. They've probably had 300 peer reviews done by them from their colleagues during the course of their training. So they are not shy to show people their resume, to stand by it, to show why you can trust them and why they're credible. And honestly, that should do nothing but increase the trust they have between the patient and the physician. So I'm totally for all that. But yeah, I think, again, that's the big thing with how physicians are trained. Some do a fellowship, some don't. Some do a board certified fellowship, some don't. So the training across the whole spectrum is going to be varied. And then, even still, what they decide what they want to do with a person with pain is going to be varied. And, the whole concept of getting any two doctors to agree with each other is really a far-fetched thing, unless it's to reduce the patient's opioid use. I mean, once again, I hate to say it, but that's the reality. So you have to know these things going in so that you can have an effective relationship, so that you can get your goals met in an effective way. And, again, if all your doctor is going to do is chew you up, spit you out, well, hopefully you figured that out sooner than later so you don't get harmed in the process. So, yeah. I would say these are the things that can make a big difference. I'm just one physician speaking on it. You may not always like what I have to say or how I say it. That's okay. I can promise you I mean no ill will. But I'm just here doing me, trying to be as effective as possible. Let me ask you, who else in this field is willing to stick their neck out and talk like this? Because really, and I'm not saying anything I'm doing is controversial, not by any stretch, but I was thinking about it. What other pain doctor is hosting lives like once a week, right? Or has the intention to continue hosting lives once a week? I mean, there's only like 2,500 of us. I mean, I don't know if you realize that or not, but there's only 2,500 board certified pain management physicians, give or take, in the country. To put that in perspective, there's probably 100,000 family medicine doctors. There's probably 200,000 internal medicine doctors, right? So pain management is really a pretty small field especially considering the number of patients that could benefit from seeing a good pain doctor. But I was thinking to myself, why aren't there more people doing this? Because there seems to be a huge need for it. Even still, I can only see so many patients in my clinic. So my whole idea was to maximize my impact in a positive way would be to go online, but nobody else is doing this. Granted, probably at least half or more of those 2,500 doctors are employed by somebody else, and so they're contractually restricted from doing something like this. And then if you own your own business, probably you're too darn busy to set up something like this and do it, right? It's not like we're making any money on this. So really, this is just a way that we can engage the community and really make an impact on a broader scale. That's my hope anyway. And, quite frankly, it's been surprising since we've started all of this. Just the feedback, the messages that I'm getting, the phone calls that I'm getting. It's really quite amazing to see the need that is there. And on behalf of all pain doctors, I'm sorry. That's just the bottom line there. I'm sorry that a lot of you have experienced the things that you have. My hope is that through improving communication, collaboration, education, we can sort of change the narrative and bring back what it was that got us started along this path. Let's say even back in the 90s, right? Pain is the fifth vital sign. Do you know why pain wasn't a vital sign before? Well, I don't know why it wasn't, but I can tell you it resulted in a lot of neglected pain. That's just the bottom line. So with my optimistic, straightforward thinking here, I would like to think that introducing pain as the fifth vital sign was really an attempt to address an unmet need. Of course, things didn't always go according to plan. Big industry got involved, big money got involved, and things sort of spiraled from there. But I want to bring it back to that. Now is a great time to address things from a different perspective. I mentioned earlier that there's so much variation across the field, our small field, with regard to training and the procedures that are offered. Half the reason for that is because a lot of these procedures came out just in the last 5 to 10 years. Viadisc, Reactivate, peripheral nerve stimulation. is relatively new. Spinal cord stimulation has been around for quite a while, even close to 50 years. But the technology has advanced more so in the last 5 years, really, than the previous 50 years combined. So, take that for what it's worth. A lot of the problems that continue to circulate through the community as it relates to spinal cord stimulators has a lot to do with the technology that was 10 years, 15, 20 years old. A lot of those problems have been solved. Not all of the problems, but fortunately they're quite rare. At least that's how I understand it as it is currently, which is great news. Now, that's not to say that you should be forced to any treatment. That's not to say, your doctor should suddenly abandon you once the stimulator has been put in. That is, I would say that is reportable to the state. But we have got options now. We didn't have these options 10, 15, 20 years ago, or since the dawn of time. So, these are the questions that you need to arm yourself with, and that's what we're going to talk about more on this channel. What you can do, what is being done, maybe things that I don't recommend. And we can address your questions, we can hear you, validate you, and plan on moving forward in a positive way. That's my dream anyway. And hopefully that means something to you. And that's something you can benefit from. I mean, if not, well, then I guess we're all wasting our time. But, that's where I want to take it next. And I'm not privy to make this announcement yet, but I will say we do have something really big coming up. Kevin, is it next week? I think I can make the announcement next week.
I don't want to be ahead of myself, but I believe so.
Yeah.
I think the next stream.
Yeah, the next stream. So we got something big that we're announcing in the goal of growing this movement of providing our community with resources and education and community. And so hopefully that is something you will tune into next week, and we can certainly talk some more about it. So that's my spiel tonight. Let's get into the comment section. Let's see where we're at here. Hello, everyone. Thank you so much for joining tonight. I'm going to make this full screen here. Okay, wow. Thank you, everybody who is joined in tonight. Valerie, nice to see you. We are invisible no more. Always a solid. You got the little crown with the number 1 on there. That's good. Hey, Lugnut, good to see you again. Jennifer. Chris RN. Are you an RN, Chris? Just a hunch. Susan Downing's got a number 3 next to her name. Kevin, you're going to have to explain to me what these mean one day. We appreciate you sharing your knowledge. Thank you, Susan. I don't have a lot of knowledge, but I have a little bit, and I'm hoping that you guys can teach me too. Vet offices generally don't schedule on Fridays for that reason. Complications happen. Well, that is exactly true. I mean, so this was a true story, and you guys wonder why we can't. Let's say you go in and you just get a simple epidural injection, right? I mean, the epidural injection is probably the most commonly performed pain management procedure in the United States since forever, and by the way, to the point where it doesn't even pay anything anymore. Maybe that's another topic, but I actually make more money seeing a patient in clinic than I do putting a needle in your back, if you can believe that. But that's beside the point. So it's very commonly done, very low risk procedure. Of course, low risk not meaning zero risk, right? There is always a risk anytime a needle punctures your skin. But anyway, there was this patient, and I will refrain from describing the location and the time and all that good stuff, but it was not my patient, I will tell you that. And this patient had an epidural injection and did not do anesthesia. So you don't need to do anesthesia. You can just do local anesthetic and numb you up and then do the procedure and send you on your way. Well, perhaps a lot of you who've had this done think that it's a little bit ridiculous that you need a driver in order to take you home, especially, if you don't have anesthesia. You feel fine, you look fine, you're walking around, no big deal. It's like you just had a flu shot or something. Well, this one particular patient decided to drive herself home and was let to drive herself home. And as she was leaving the parking lot, she apparently couldn't move her foot very well, to the point where her leg became paralyzed and she couldn't hit the brake, and she ended up driving straight into a tree. Fortunately, she wasn't going very fast, but it was enough to cause a ruckus, you can imagine. She ended up suing the hospital and winning because she was let to go home without a driver. Well, it turns out in her case, she developed a small hematoma in her spinal cord, and that caused some pressure on that nerve, and her leg stopped working. I've only ever seen this happen one time in my entire career. I know I've been practicing for 50 years, but no, I've done a lot of epidurals, seen a lot of epidurals. And, once that happens, you go back to the hospital, they perform a minor surgery for you. It's not fun, but they were able to stop the bleeding, and I'm sure she made a complete recovery just based on what I know. So that is the reason why perhaps a lot of you are required to have a driver no matter what. And that is why I require my patients to have a driver no matter what. But yes, I say that because complications can happen. They can happen in 15 minutes as soon as you leave the hospital. They can happen the next day. They can happen in 3 days if you start developing a fever and chills and you start getting confused because you have meningitis, right? So definitely you don't want to go home on the weekend and, sort of be out there in the middle of nowhere when something bad happens. That just makes good sense.
I'm going to jump in here real quick. Sarah, she has a question for you. It's a little off topic, though. She's asking, first off, have you ever treated CRPS?
Complex regional pain syndrome.
And then a little more specific, with the support of consistent IV hydration?
With the support of consistent IV hydration.
And we'll get a little bit more specific, especially during a flare. Is that even a reasonable idea or request?
That's a great point. Yeah, so I would say complex regional pain syndrome. By God, you don't want complex regional pain syndrome. It is a nightmare of a condition. And if you have this and you're listening to this, I am sorry that you have that. But there are treatments for it. That's the good news. Actually, this is off topic, but I've actually found a lot of success using oral ketamine for the treatment of CPRS, complex regional pain syndrome, CRPS. In fact, you can watch some of the videos we have already. There's a video, I interviewed a patient by the name of Nelda. She's on the podcast here. This was a while ago. And she volunteered her time to come on and share her story. And it is amazing to see everything she's gone through, actually. She's, doing great. She actually asked me the other day to come back on again to show her progress. But so, yes, I'm familiar with complex regional pain syndrome. I'm familiar with various treatments that are used for it. Whether you want to hear this or not, I'm just going to say it. The standard treatment, the standard definitive treatment for it is a spinal cord stimulator. There happens to be a robust amount of evidence to support the use of it. Nelda opted to not have it, actually. Well, actually, that's not true. She had one that was a long time ago. She'll tell you in the podcast. But it was old technology, didn't work too well, and as of recently, we found better results with the ketamine. But so there's that. There's injections that can be done. Sympathetic blocks, most commonly. It's a type of injection that occurs in the front of your spine, actually. So if the problem is in your arm, then we may inject a bundle of nerves right here at the base of your neck. That can last 6 months on average, give or take. If the problem is in your leg or your foot, we can inject a bundle of nerves in the front part of your lumbar spine. So those are both options. But I can tell you from my perspective, I get the best results putting a stimulator in and getting that done. Now, the idea behind IV hydration, I've actually not used that. I would be open to trying it. It makes sense why it might work, especially during a flare. The affected limb will have changes to the blood flow. Sometimes it'll be too much blood and the hand will get red and flushed. Sometimes it'll be too little blood and the hand will sort of shrivel and turn white. So the idea behind IV hydration would be to maintain a certain level of pressure and blood flow. At least that's how it might work in my head, but I would have to do more research with regard to the actual studies behind that. Seems like a good option. Yeah. Good question.
I got something a little off topic that I just keep getting, I keep hearing this brought up. So I don't know if you want to address this in a stream or maybe you could touch on it tonight, but I often hear these three things: ketamine, CBD, cannabis.
Yeah, definitely we need to talk more about all those things. That's for sure. And I mean, that's where it's going too. Anything but opioids, right? That's where the whole field seems to be going, whether you like it or not. I mean, and that's why we have to educate ourselves and make sure we know what our options are, because if we don't, we may not be told, right? That's the sad part. But yeah, I would say CBD is real good. We actually sell our own brand. Not that I'm using this opportunity to sell it, but we do. It's in the clinic. And the reason why I got my own brand is because if you go to any particular head shop and self-medicate, so to speak, the chances of you failing a drug screen is pretty high. It's an unregulated, in most cases, unregulated product. And so even though it doesn't say it has THC in it, which is the active illegal compound, but it still may have THC in it. So when you think you're taking straight CBD, and then you go to your pain doctor and you do a drug screen, you pop THC, and now suddenly you're the villain, and you're non-compliant, and you get a label put on you, and this whole thing. Well, I didn't particularly like that, not only for my patients, but just in general. So we started our own brand. Ours comes from Colorado. It is pure. We have pure CBD, and we also have THC products as well. What's nice about these canisters is that they're all third-party tested. So whether you buy from me or you buy anywhere, just make sure that it is third-party tested. There's a QR code on our bottles. You can plug it into your phone, and it shows you the report generated by the third party that is ensuring the quality of the ingredients that are in that bottle. So yeah, I think it's great. CBD, like everything in pain management, it's very divisive. A lot of times patients are like, well, it didn't work for me, so it shouldn't be offered to anybody. I mean, I think that's a little ridiculous, but you guys are smarter than that, so I'm not going to go down that road. But, I would say, especially for the person that is in that 5 to 6 year period before they're waiting to see a pain doctor, and get on a stronger treatment program, whatever that might be, I think that's an excellent choice for most conditions. There's great evidence behind it. Neuropathy, osteoarthritis, anxiety, insomnia, right? A lot of these symptoms that contribute to chronic pain. Now, I'm not officially giving advice on what specifically to take or how to take it or the doses or anything like that. Definitely you should read the label, take it as directed, talk to your doctor about it. But I think to rule that out as a potential treatment option would be foolish. Same thing is true with ketamine. Ketamine is, I don't know if it's making a comeback, but it's really making some headway, I think, certainly in the treatment of depression. We see that a lot. It's been used historically in pain management. It still is through the IV. I would say with varying results. Some good, some, meh. Definitely you want to make sure, again, you know who is running your IV. That's a cash-based system in most cases, and so it might be $1,000, $1,500 per IV infusion, and maybe a lot of companies try to, fly under the radar with less than qualified personnel pushing the IV. So definitely do your research on that. But yeah, no, that's an option. But I think what maybe contributed to the oral form was just the cost and the access is much greater. This is just a compounded medication that a compound pharmacy can create for you. Just a small dose, microdose really, of ketamine. And what it does is it reduces the amount of glutamate in your brain. So how we understand chronic pain, especially as it relates to, let's say, failed back surgical syndrome, right? You had back surgery, but you still have pain and it's been going on forever. Or complex regional pain syndrome, or really any type of chronic pain condition. The longer you have it, even though you fixed the problem in the periphery, your brain remembers this. So, and this is one of those cases where we say the pain is all in your head. I don't mean that psychologically. I mean literally, it centralizes the circuits centralized to your brain. Just think of it like phantom limb. That's kind of how I describe it. So if you cut off your foot, chances are you're still going to feel your foot, even though it's not there, right? That's because you've lived your whole life with your foot. And the pathways that sense your foot and the patterns and the neuro connections in your brain all still exist. So that's how you can still feel it in your brain. When it comes to chronic pain, there's a very distinct process where your pain centralizes, call it centralized pain. And a big driver behind that is the neurotransmitter glutamate. And that attacks, I don't want to say attacks, it attaches to your NMDA receptor. And so the idea behind ketamine is that it blocks your NMDA receptor. And so it reduces the whole feedback system within your pain. So we'll talk about more all of this later on, but yes, I think there's significant applications for CBD and ketamine.
So I remember when Nelda was in studio and she gave her testimony. I guess my question, which it was in my head, but someone brought it up, how would you address that with your PM? Like recommending ketamine?
As a patient?
Correct.
How would you approach your pain doctor?
Correct.
I mean, it could just be a simple question. Usually I like to go in with research. I think that it puts your doctor on guard a little bit. That's true for all of y'all. Anytime you go in with research, your doctor is going to think twice before he walks into your room. Absolutely.
So you got to play it dumb.
No, you gotta play it smart. You gotta play it smart, right? So like, if you're seeing 30, 40 patients a day, and you know that your patient is liable to be very passive and just go, yes, doctor, the whole time, then probably it's just human nature that your encounter with that patient is going to be rather short, sweet, to the point, and driven however you feel it best to be driven as the physician. If you come at it with questions, now the doctor has to stop, critically think for 5 seconds, which is what you're paying that doctor to do, and apply that knowledge and experience to your case. Now, it's one thing to just ask questions. If that's all you can do, by all means, do it. Again, your doctor should invite questions. If your doctor shuts down your ability to question or dismisses you or treats you as less than, then that is a huge red flag. We always talk about patient red flags. That is a doctor red flag. Because now the doctor showing his cards or her cards. They're saying, I care more about me than I do you. So I'm not going to spend the time to educate you. That's a problem.
So just for the sake of argument, and I'm going to need a little assistance on this, but let's try a little role play. All right, I'm going to be a patient. I'm going to try and play this smart, and maybe you can shoot me hands up for a red flag, or
okay,
maybe a thumbs up for good move. Because at the end of this, I would suppose, I don't really want this to seem like it's my idea of you recommending this to me, but I want it to be your idea of you bringing it to the table and me saying, yeah, I think that's playing it smart. Am I close?
Sure.
Gotcha. So go ahead.
I'm the patient?
No, I'm the patient.
Oh, hello, Mr. Producer. What brings you to clinic today?
So first off, thanks for taking time out of your day to see me.
Yeah.
I've really been having some neck pain that kind of trickles down my back from some time. And, it's got me in this state of depression because I just can't do the things that I used to do. And, I look at my kids and they're wanting me to tickle them and pick them up. And that's just out of the question.
Yeah, sounds like you've been living with this for some time now.
I have, actually, yeah. This probably started, I don't know, maybe 2 years ago. And, it started as a little twinge in my neck. And then sometimes I'd feel it, shock me down the back. I really didn't do anything about it then. But as it progressively got worse and I saw that it was really stimulated during, like, playtime with the kids, I at some point, I had to come in.
So you know what I'm liking about this already?
No. I mean, I don't.
You're approaching the situation from a functional standpoint.
Okay.
Right? You're not coming in saying, "Hey, doc, I need some pain medicine." You're not coming in all aggressive and demanding and all these things. You're coming in saying, "Hey, I'm like in a lot of pain here, and it's affecting my ability to live life in these ways." Now, what that's doing is it's creating this emotional response in me, because I hear pain scores all day long. I mentioned this before. They almost mean nothing, right? Everybody's got 8 out of 10 pain. Everybody's got 10 out of 10 pain. What matters is how that's impacting your life and how you can articulate that. And I bet as a patient, you're going to get a response that is much more meaningful, because now I can align myself with you. Well, I love picking up my kids. I feel bad now that this patient can't. And because I feel bad, I want to do everything I can to make myself feel better and help this patient. All right.
Okay, so let's proceed now. I full disclosure, I take a lot of Motrin. Like the 200s, I can take 10 of those easy in one setting.
Yeah.
I know it's probably not recommended, but at least gets me to a position to where I can manage things.
Right.
But I don't want to be killing my liver.
No,
or
you
kidney
do not.
or whatever is down there that processes
Kidneys and liver, yeah.
Wow.
Well, that communicates to me that you've been proactive in attempting to ameliorate your symptoms, but you're exhausting the options that you have available to you, so that my input is really justified. It's required, and quite frankly, a little bit life-saving, because if you're taking really that much ibuprofen, you may end up really doing some harm. And by the way, that is a topic you need to remind me. We need to circle back on this. NSAIDs.
What is that?
Non-steroidal anti-inflammatory drugs.
Right.
Anti-inflammatories like ibuprofen, naproxen.
I've seen that on the back
Aleve,
of the ICS or something like that.
NSAIDs. Oh my goodness. We need to do a comparison head-to-head, the dangers of NSAIDs versus the dangers of opioids.
Get out.
Now,
They're on the same playing field, or?
Depending on the research you look at, let me just give you a little teaser. NSAIDs are extremely dangerous.
Wow. So I would have been better off on opioids?
Individualized care. Some patients maybe one versus the other, but let's just put it this way. Just because it's over the counter doesn't make it safe.
I gotcha. Right. Yeah, I see what is being brought up, at least with Tylenol.
Tylenol, man. Oh, yeah. You know how many liver transplants Tylenol is responsible for? You would think it's alcohol is most common.
A lot.
Yeah, it's either number one or number two. The most common reason for liver transplant is Tylenol. So, yeah, I mean, again, it all comes down to individualized care. Yeah, Jennifer, you got that correct. What is right for one person may not be right for the next, whether that's medication, whether that's psychology, whether that's some type of intervention. And so that's the whole point of all of this. If we were to put it into a nutshell, it's so that patients can better understand doctors, doctors can better understand patients. We can come to the table in a collaborative approach that allows individualized care to blossom. And boy, I'll tell you, if it doesn't, that's where problems happen, man.
All right. So lastly, because I want to get to where you recommend me what I'm going for. All right. So I think I got a phrase. I like working out in my wood shop, and I have a tool bag. And in there's a screwdriver, a hammer, a drill, some nails, and so forth and so on. All right.
Yeah, I know where you're going with this.
What can we put in my tool bag
Yes.
of individualized care so then I can look at what I have within my, perspective of options and make a pretty informed choice from there. And maybe, I don't take whatever you're recommending now as like, hey, yeah, just write me the prescription. But at least let me know what to put in the tool bag. And then if I have to, I can go back home, do a little bit of research, and then come back to you and say, or call, and hey, you know what? I think I'm on the line. I feel most comfortable with this one. Yeah.
No, exactly. I'm going to leave you with a story.
Okay.
Actually, this happened to me last weekend, 2 days ago, this last weekend. And so over Christmas break, I took my daughter ice skating for the first time. She's 8 years old. She just turned 8. And I got to tell you, she was a natural. I mean, she gets on the ice. She's doing her little loop-de-loops, her little twirls. I'm like, have you been ice skating your whole life? What is going on here? Her brothers, like, falling all over themselves, and it was a lot of fun. But this last weekend, I decided to take her back to the ice skating rink over at the mall and get her some lessons. So she had a lesson and was doing real great with that. That's not part of my story. That's just to lead up to it because I really like talking about her. Anyway, so we ended up going to get some food afterwards. We went to Five Guys. Got myself a burger and some fries, and it was a good time. And I went to the bathroom afterwards. Now in the bathroom, there's a sign. You know how they have like Five Guys branding all over the place? Well, the sign said 15 different ways to have your sandwich, right? Because they were advertising all the different toppings that you could put on your burger. And I was thinking to myself, what in the blue blazes? This is a burger joint. I went to school for 15 years with people that trained me doing pain management for 20 years longer. And I was thinking, if I were a patient and I randomly went in to get treatment for something, would I get 15 options to treat my pain? And if not, why the hell not? We like to walk around and boast about our education and our tools and all the things that we can do. But I bet you anybody in this chat right now would tell me, no, my doctor didn't give me 5 options to treat my pain. Get out of town, man. That's insane. The doctors are being beat by the burger makers, right? Like, nothing against burger makers. It was a delicious burger, well worth the money. But do you think they went to school for 15 years? Like, no. So there is a huge problem when it comes to the healthcare system. But I mean, especially pain management. That's really what I want to focus on. I can't speak to the other specialties as much, but that struck me.
So what's in my toolbox?
For your neck,
back, whatever we got to do in
oh
depression.
man, there's so many things we could do.
Really?
First of all, and I will tell you this, a lot of the problem comes from not understanding the disease process. If your doctor's not touching you, that's a problem. If your doctor's not examining you in different positions, that's a problem. If there's not nerve studies or images or some other form of diagnostic tool to figure out exactly what's going on with your body, that's a problem. If your doctor's not asking good questions or reciprocating the fact that they understand or hear what's going on, that's a problem. How can they even think of a solution if they're not even understanding the problem? So that's really where it starts for me, is really building that rapport and understanding the problem up front. And then from there, the options become very clear. And they should be delivered in a way that gives the patient buy-in, that gives the patient, that protects the patient's autonomy, right? Their consent, so that, they're not feeling like they're being hoarded into a treatment protocol that may or may not apply to them. And, even if there is only one option, it should be explained that way. It shouldn't be, well, it's my way or the highway. It shouldn't be like, well, I can't help you otherwise, and then just walk out of the room. No, explain your options. And if you don't have any other options, then refer to someone that does. What you don't do, going back to Sarah and her predicament, is walk away from it. I mean, that's just, borderline patient abandonment. But again, I wasn't there. I don't know the details per se. But based on what I heard, I mean, not good. So yeah, I would say there's lots of different treatment options, whether it's medication management, whether it is a natural supplement program, whether it's are we having some technical difficulties?
Yeah.
Hold on, guys. We're having some technical difficulties. Don't go anywhere. Okay, am I back? Okay, cool. Yeah, so there's lots of over-the-counter remedies, natural supplement remedies, exercise remedies, psychological interventions, and then, of course, different procedures. I mean, just for the low back, there's probably 10 different procedures that I've been trained on in the last 5 years because they're all relatively new, right? But it seems like so many doctors are like stuck in this cycle of epidural injection, medial branch nerve block, rhizotomy. Epidural injection, medial branch nerve block, rhizotomy. And then if you're lucky, you may have someone that feels good about doing a stimulator, but then sometimes that's all they offer. Sometimes clinics make their entire business off of peripheral nerve stimulators. So, I mean, not everything has to be a one-stop shop either. So if we have to work within the system that we are forced to work into, or, work in with, then, maybe you need to have like 2 doctors that are managing your pain.
Well, you know something? I'll give you one doctor. My church priest.
Yes.
But look, on the spiritual side, sure, I've prayed about it. I'm under the belief God made doctors. God made brains. Doctors have brains. They also made medicines. So can you give me some sort of medication, Like, I'm not against, I don't want to call them hard drugs or whatnot. I don't want to go to like the street pharmacists. I'm not trying to get out there with Joe Blow on the block, because I'm sure he has a lot of things that could address a lot of things, especially the ones that put me 6 under.
Yeah.
So realistically, I'll put it to you this way. My wife, she's afraid of me being on certain drugs. I don't know anything about anything.
Right.
But I know I've had friends that tell me all kinds of crazy stuff. Like, I've heard of opioids. I've heard them on the news. On one side, I've heard a lot of people have a lot of problems. On the other side, I've got personal friends that swear by it.
Yeah.
And I've heard of other crazy stuff too, like, I don't know, what is it called? Something infusions or something. Starts with a K. K-pop. Calypso.
Ketamine?
There we go. Yeah. So I've heard of that. I'm just not the educated one, so.
Yeah, no, and we'll get into all of this stuff. You know, obviously, if you can avoid medications in general, that's better. Every medicine has some side effect. Every medicine has some long-term effect. People are talking about gabapentin now contributing to dementia, early onset dementia, right? That's been announced, I don't know, 3-6 months ago, something like that. Well, a lot of people are using that as arguments to go to opioids. But what they don't realize is we've been saying that about opioids for even 10 years. So every medication really has some deleterious effects long term. But that's the point, is that it's a risk-benefit ratio. If it's helping you more than it's harming you, it may be worth it. But again, it depends on the medicine, depends on the treatment, depends on the patient, depends on the doctor, so many things. But that's it. That's how we have to learn how to work within the system that we have. So
I got it. So I guess, lastly, if you could just give me 1 or 2 in the box, and you don't have to do it now, but 1 or 2 in the box kind of treatments, and 1 or 2 maybe outside of the box, and I think I'd be good from there.
Well,
just within your
typically speaking, let's say for radiating type neck pain, I've not examined you and I've not seen imaging, so just hearing what you have to say, I would say a course of strength training with a focus on range of motion and stretching of the neck, maybe some physical decompression would do you some good. Okay. You may combine that with some laser therapy or acupuncture if you find someone that is well trained in that. I would provide a TENS unit for you to use while you're at home watching TV and you feel like you'd rather use that instead of taking some medicine. And then perhaps a topical pain cream of some kind. I think that's a real conservative, multimodal approach right out of the gate to get you feeling better. Most people will get better with that sort of approach as well. About 50% in 2 weeks, about 80% in 6 weeks will get to the point where they don't feel like they need to follow up with their pain doctor.
Gotcha. So you don't think I really need meds so far?
It just depends. You may benefit from an anti-inflammatory, maybe a muscle relaxer, and we can go from there.
Gotcha.
But there's still a lot of variables for those of you listening that have not been mentioned that would need to be taken into account. But that's just off the textbook, shooting from the hip.
Sure. I appreciate that.
Yes, just on B, I hadn't heard opioid use. Yes, it sure can. Well, and again, it's not causative. None of these studies are causative. We can't prove causation, right? We can improve association. So just like they did with gabapentin, the longer you've been on it, the higher the dose, the more likely chance there is to be earlier onset dementia. The same is true with opioids. And we knew that long before the information about gabapentin came out. I'm going to run through these comments here real quick. Try not to leave anybody out because we are at our hour tonight. Let's see. I wish CBD and THC worked for me. Yes, Chris, I wish it did too. It works for some, not for everybody.
Well, Jamie Bates here, she, or he, not sure, brought up real quick, is there something you could at least address with whatever the 3 types of pains are? I think you brought it up in one of the past videos, but I don't think they may have.
Oh, yeah. Okay. So, yeah, the 3 types of pain, nociceptive pain, NOCI, CEPTIVE, nociceptive. You hit your hand on the table, bang, it hurts. That is a normal response pain sensation. We call that nociception pain, nociceptive type pain, musculoskeletal type pain. Then there's neuropathic pain, meaning nerve pain. That might be more associated with neuropathy, diabetic polyneuropathy, carpal tunnel syndrome, sciatica, things of that nature, is a different type of pain. And then, of course, there's nociplastic pain, which is the type of pain that I was describing earlier, the centralized pain problem, including things like fibromyalgia and complex regional pain syndrome and things of that nature. And all three of those types of pain work differently, different mechanisms of action. We understand on a physiologic basis, so they actually respond differently to different medications. So I think identifying that type of pain up front will definitely direct the plan of care. Yeah. Just Dawn DB said, my pain management doctor deferred prescribing an opioid to my general practitioner. Yeah, I understand that. So let me give you some insight there. Do I think pain management doctors should have opioids in their toolbox? Yes, absolutely. I don't understand pain doctors that don't at least have it in their toolbox. Yeah, I mean, honestly, that's like a sandwich maker not knowing how to make a hoagie. Like you got to at least know how to make a hoagie. But there may come a time when that physician is maybe so bogged down with opioid prescriptions, or maybe that doctor wants to focus more on the high-risk prescribing, right? Where that special training and expertise may play a more critical role. That a lot of the more stable patients that have, maybe been on that for a long time without really changing anything, it's a low dose, that type of thing, the risk is really quite low. It makes sense to transfer that patient back to the general practitioner, because, again, there's only 2,500 of us, give or take, and there's 100 million people with pain. So if we were all to just prescribe opioids, we'd be missing out on helping a lot of patients. So I hope that answers your question. Yeah, wow. My current pain management doctor was the first out of 6 doctors we saw. He was the very first to physically examine me. Yeah, I'm telling you, man, it's crazy how common that is. I'm glad you found a good one. Yeah, that seems to be a common issue. I did pay my light bill. We are invisible no more.
We were invisible for a moment.
We were invisible for a moment, but now we're invisible no more. Yeah. I mentioned imaging. So Jennifer says, I mentioned imaging to Kevin. A lot of us have structural damage, spinal cord injuries, or conditions that can be seen via imaging. That's why it is so important. Oh, yeah. Oh, my goodness. No, we're actually going to get into this in the relative short future. How to properly use imaging. Obviously, you can't see pain on imaging, but it gives you a lot of insight as to what could be going on. And, I'm sort of the opinion that anybody that comes to see a pain doctor, unless you're like, you just played basketball and you rotated your ankle or something, most of the time, like I said, patients are waiting 5-6 years before they come see me. So in those cases, I'll just get imaging right off the bat. I mean, why do we need to wait? You're already seeing a specialist. It's not like your pain started yesterday. We need to figure out what's going on. My pharmacy would not fill my prescription unless it came from pain management. Yikes. Yeah, that's ridiculous. See, I don't understand all of that. I think the laws probably are different from state to state and from pharmacy to pharmacy. I don't think that's universally true. I might find a new pharmacy. Yeah, having imaging just backs up your case. Yes.
Is that something we should do ahead of time?
Having imaging?
Just to come in for the initial visits?
It certainly helps out things.
First consultation.
If you talk to your GP, if you're getting a referral to come see your pain doctor, just have your doctor at least get some x-rays. If they feel comfortable getting an MRI, even better. I'm never going to be like, oh, you've had too much imaging. Said no one ever. Right? No, but I mean, it definitely helps to, let's say, expedite your care. Otherwise, you come in, then I got to order it, and then there's like a 2 to 3 week turnaround. You got to spend, in pain. Whereas if I can see it up front, we can.
So I can go to a radiologist and say, hey, look, guys, I have neck pain. Mm-hmm. And they'll just scan my entire neck and give me some x-rays to bring in. And
yeah, I mean, they might start you off with some x-rays. They may order x-rays and MRI at the same time. Just depends.
Gotcha. I always thought that had to be recommended from a specialist or something.
No.
Got it.
Yeah.
Interesting.
No. So, all right, guys, we are over an hour. I am out of tea, and my voice is drying up. So I appreciate all the comments and the engagement tonight. This has been fantastic. Wow, 20 plus MRIs.
I was going to say the same.
That's worth noting. Goodness. Hopefully they found the problem there, Jennifer. Goodness. Again, thank you guys so much for watching, for being engaged, and for being part of the movement, hopefully to help you all and America live more with less pain. Until next time, stay safe. We do have another episode dropping Thursday at 7 p.m. This is the last in a series that Keith and I have recently done. And hopefully it strikes a chord with you and triggers some more engagement and conversation. But yes, big announcement. Next Monday is when we plan on making that. So until then, take care.